Hello everyone, and welcome back to the channel. Today, we're exploring a condition that affects millions globally each year: community-acquired pneumonia. Whether you're a medical student, healthcare professional, or simply someone wanting to understand this common yet serious infection, this video will take you through everything you need to know. So, let's begin our journey into the lungs. Community-acquired pneumonia, commonly referred to as CAP, is an acute infection of the lung parenchyma, that's the functional tissue of the lungs, acquired outside of hospital or healthcare facilities. The key word here is community. This distinguishes it from hospital-acquired or ventilator-associated pneumonia. To put this into perspective, imagine your lungs as an intricate tree with approximately 300 million tiny air sacs, called alveoli, at the end of each bronchiole. These alveoli are where the magic happens. Oxygen enters your bloodstream, whilst carbon dioxide leaves. Now in pneumonia, these delicate air sacs become inflamed and fill with fluid, pus, and inflammatory cells, essentially drowning the lung from within. The statistics are quite sobering, really. CAP remains the leading infectious cause of death worldwide, responsible for over 3 million deaths annually. Here in the UK, roughly 220,000 people are diagnosed with CAP each year, with about 30% requiring hospitalization. It's particularly concerning that even with modern medicine, the mortality rate for hospitalized patients ranges from 5 to 15%. What makes CAP particularly challenging is its ability to affect anyone, from newborns to the elderly, though certain groups are decidedly more vulnerable. These include children under 5, adults over 65, smokers, and those with chronic conditions like diabetes or heart disease. Now, let's delve into the fascinating yet concerning process of how pneumonia actually develops, the pathophysiology, if you will. Understanding this process helps us appreciate why certain symptoms occur and why treatment approaches vary. The journey of pneumonia typically begins in one of three ways. First, through inhalation, the most common route. When someone with pneumonia coughs or sneezes, they release thousands of tiny droplets containing pathogens. We breathe these in, and whilst our upper respiratory defenses usually catch them, sometimes they slip through to the lower airways. Second, through aspiration. This occurs when oral or gastric contents accidentally enter the lungs. This is particularly common in elderly patients or those with swallowing difficulties. Third, through hematogenous spread, though less common, bacteria can travel through the bloodstream from infections elsewhere in the body. Once the pathogen reaches the alveoli, a cascade of events unfolds. Stage 1. Initial colonization. The microorganisms attach to the alveolar epithelium and begin multiplying rapidly. Stage 2. Inflammatory response. Within hours, your immune system sounds the alarm. Neutrophils and macrophages rush to the scene, releasing inflammatory mediators like cytokines and chemokines. This causes the capillaries to become leaky. Stage 3. Red hepatization, named because the lung takes on a liver-like appearance. The alveoli fill with red blood cells, fibrin, and inflammatory cells. On examination, the affected lung area becomes solid and airless. Stage 4, grey hepatization. Red cells break down, leaving mainly white blood cells and fibrin. The lung appears grey and solid. Stage 5, resolution. In successful recovery, macrophages clear the debris and normal architecture is restored. However, this can take weeks to months. This entire process disrupts gas exchange, leading to ventilation-perfusion mismatch. Essentially, blood is flowing past alveoli that cannot provide oxygen, creating what we call a shunt. One of the most crucial aspects of understanding CAP is recognizing that different organisms predominate at different life stages. This age-specific pattern guides our empirical treatment choices. Let's start with our youngest patients, neonates, birth to 28 days. In these precious first weeks of life, the culprits are often bacteria acquired during birth passage. Group B, Streptococcus, the leading cause colonizing about 25% of pregnant women, Escherichia coli, particularly in premature infants. Listeria monocytogenes. Though rare, it's devastating when it occurs. Infants, 1 month to 1 year. Here we see a shift towards respiratory viruses. Respiratory syncytial virus, RSV, causes up to 70% of pneumonias in this age group. Streptococcus pneumoniae, still significant despite vaccination programs. Bordetella pertussis, particularly in unvaccinated infants. Toddlers and preschool children, 1-5 years. Viral causes continue to dominate. Viruses account for 80% of cases: RSV, influenza, parainfluenza, adenovirus, Streptococcus pneumonia, the most common bacterial cause, Haemophilus influenzae type B, now rare thanks to vaccination. School-aged children and adolescents 5 to 18 years, we see the emergence of atypical bacteria. Mycoplasma pneumonia causes up to 40% of CAP in this group, often causing walking pneumonia. Chlamydophila pneumonia, another atypical organism, Streptococcus pneumonia, remains important. Young and middle-aged adults, 18-65 years, Streptococcus pneumoniae, responsible for 30 to 50% of bacterial CAP. Mycoplasma pneumoniae, common in younger adults, viral causes, influenza, and more recently SARS-CoV-2, Legionella, in specific exposures, air conditioning systems, hot tubs. Elderly, over 65 years. The spectrum broadens considerably. Streptococcus pneumoniae, still the champion. Gram-negative bacteria, Klebsiella pseudomonas, especially in those with chronic lung disease. Staphylococcus aureus, particularly post-influenza. Aspiration pneumonia, increasingly common due to swallowing difficulties. Now, how does pneumonia actually present? The clinical picture can vary tremendously, from subtle to dramatic. The classic presentation. The textbook patient with bacterial pneumonia typically experiences an abrupt onset of symptoms. Respiratory symptoms, cough, initially dry then productive of purulent sputum. The sputum color can provide clues. Rust-colored suggests Streptococcus pneumoniae. Green indicates pus, whilst bloody sputum might suggest more serious complications. Dyspnoea, shortness of breath, initially on exertion, progressing to rest. Pleuritic chest pain, sharp stabbing pain that worsens with deep breathing or coughing, indicating pleural involvement. Systemic symptoms, fever, often high-grade, 39 to 40 degrees Celsius, with rigors or shaking chills, malaise and fatigue. Patients often describe feeling knocked for six, myalgia, muscle aches throughout the body, anorexia. Loss of appetite is nearly universal. Physical examination. Findings. When we examine a patient with pneumonia, we're looking for specific signs. Vital signs. Fever, though elderly patients may be afebrile. Tachypnoea, respiratory rate, 20 per minute in adults. Tachycardia, pulse, 100 per minute. Hypertension in severe cases. Oxygen saturation, 95% on room air. Chest examination. The classic findings over the affected area include inspection, reduced chest expansion on the affected side, palpation, increased tactile vocal phrenitis, vibrations felt when patient says 99, percussion, dullness over consolidated lung, auscultation. This is where it gets interesting. Coarse crackles or crepitations, like the sound of hair rubbed between fingers near your ear. In advanced consolidation, you might hear bronchial breathing, high-pitched breath sounds normally heard over the trachea. Atypical presentations. However, not everyone reads the textbook. Atypical presentations are common. In the elderly, confusion or delirium may be the only sign, falls or functional decline, absence of fever, exacerbation of underlying conditions. In children, poor feeding in infants, abdominal pain, lower lobe pneumonia, vomiting, lethargy without localizing signs. It's absolutely crucial to recognize when pneumonia is becoming life-threatening. These red flags indicate severe disease requiring immediate medical attention. Signs of respiratory failure. Respiratory rate, 30 breaths per minute, use of accessory muscles. Seeing the muscles between the ribs pull in, cyanosis. Blue discoloration of lips or fingers. Inability to speak in full sentences. Signs of sepsis, confusion or altered mental state, systolic blood pressure. 90 mHg temperature, 36 degrees Celsius or to 40 degrees Celsius, heart rate, 130 beats per minute, mottled skin or prolonged capillary refill, laboratory red flags, white cell count, 4 or 20 Q109L, urea, 7 mmol LPO2, 8 kPa or SaO2, 92% on air pH, 7.35. We use severity scores like Curb 65 to assess risk. Confusion urea, 7 mmol L, respiratory rate, 30 min, blood pressure, systolic 90 or diastolic 60, age 65. Each criterion scores 1 point. A score of 3 or more indicates severe pneumonia requiring intensive care consideration. Treatment of CAP involves both supportive care and targeted antimicrobial therapy. The approach varies based on severity, likely pathogens, and patient factors. Outpatient treatment, mild CAP, for patients well enough to be treated at home. First-line antibiotics, amoxicillin, 500 mg 1g 3 times daily for 5 days, UK guidelines. For atypical coverage or penicillin allergy, clarithromycin or doxycycline. Supportive measures, adequate hydration, at least 2 liters daily, paracetamol for fever and pain, rest. The body needs energy to fight infection, avoid cough suppressants. Coughing helps clear secretions. Inpatient treatment, moderate to severe CAP. Hospitalized patients require more aggressive treatment. Antibiotic therapy, coamoxiclav plus clarithromycin, providing broad coverage. For severe cases, add gentamicin or consider coamoxiclav plus levofloxacin. Duration, typically 7-10 days depending on response. Supportive care, oxygen therapy to maintain saturation, 94%, 88 to 92% in COPD patients. Intravenous fluids for hydration, thromboprophylaxis. Pneumonia increases clot risk, chest physiotherapy in selected cases, nutritional support. Monitoring, daily observations and news scoring. Repeat chest X-ray if not improving. Blood tests to monitor inflammatory markers. Special considerations. For suspected atypical pneumonia, Mycoplasma chlamydophila. Macrolides or tetracyclines are preferred. Beta-lactams are ineffective as these organisms lack cell walls. For suspected aspiration pneumonia, add metronidazole for anaerobic coverage. For influenza-related pneumonia, consider oseltamivir within 48 hours of symptom onset. Watch for secondary bacterial infection, particularly Staphylococcus aureus. So there we have it, a comprehensive look at community-acquired pneumonia. From the microscopic battle in your alveoli to the clinical signs that doctors look for, we've covered the essential aspects of this common but potentially serious infection. Remember, whilst most cases of CAP can be successfully treated with antibiotics and supportive care, prevention remains paramount. Simple measures like hand hygiene, staying up to date with vaccinations, including pneumococcal and influenza vaccines, and avoiding smoking can significantly reduce your risk. If you found this video helpful, please do give it a thumbs up and consider subscribing for more medical education content. And remember, if you're experiencing symptoms of pneumonia, particularly any of those red flags we discussed, please seek medical attention promptly. Thank you for watching, and until next time, stay healthy.